So thanks so much for joining on this Sunday. As you heard, I'm going to be giving a little bit of information about medicinal cannabis for chronic pain. Terms of disclosures, I have received some federal funding and done a little bit of consulting to Health Canada, but I have no for-profit relationships to declare. In terms of background, this will be well known to most, I suspect, but cannabis has been legally available for therapeutic purposes in Canada, at least for some conditions, since 2001. In October 2018, they legalized non-medicinal cannabis as well. And licensed healthcare practitioners can provide authorization for patients to acquire medical cannabis. Most products do not have a drug identification number and so can't be prescribed, but authorization can be provided. And Health Canada tracks the number of authorizations that have been granted in Canada. And these numbers have gone up quite substantially in the recent past. In 2015, there were just shy of 24,000 Canadians that were authorized to use medicinal cannabis. And by September 2020, this number had gone up to close to 400,000. So there's considerable interest. This is only the numbers of patients that have been authorized. There's quite a few that are using cannabis for therapeutic purposes without authorization. So it's certainly a topic that seems to be growing in interest amongst patients. In terms of financial implications, just to give a sense, Veterans Affairs Canada in 2018 paid out $75 million for reimbursement of medical cannabis for veterans. Last year, that number is now north of 100 million. So again, substantial expenditures and increasing. So what are patients largely using medicinal cannabis for? Well, this is data that came out of the US recently. This was a study looking at over 800,000 medical cannabis license holders in 2017. And as you can see from the graph here, the predominant condition by far is chronic pain, which 62% of patients reported was the qualifying condition for their cannabis license. Now, there have been some recent reports looking at guidance for using medical cannabis for chronic pain. One came out from the UK, from the NICE organization. This draft version came out in 2019. It was formalized in 2020, and they made a strong recommendation against the use of any form of medical cannabis in the management of chronic pain. More recently, the International Association for the Study of Pain, just earlier this year, as fact, also came out with strong recommendations not to use cannabis for management of chronic pain. So is this the final story? I'm not sure. We embarked on a sort of similar initiative to these two organizations. We looked at a focused clinical practice guideline. And our question, as you can see here, is in adults and adolescents living with chronic pain due to cancer or non-cancer causes, should there be a recommendation to suggest a trial of medical cannabis or cannabinoids or not? And the recommendation could be strong or it could be weak. Strong recommendations mean that all patients given the same information or almost all would make the same choice. And a weak recommendation is more of a candidate for shared decision-making. It either means the evidence is not very good or that we have a very close balance. So we use the GRADE approach. And just to reiterate, in order to make a strong recommendation, we would require there to be a clear imbalance. Either the benefits clearly exceeded the harms, in which case there could be a strong recommendation in favor, or the harms clearly exceeded the benefits, in which case there would be a strong recommendation against use of cannabis. We would require good confidence in the evidence. It would have to be of good quality, and we'd have to believe that all patients given that information would make the same decision. A weak recommendation, on the other hand, would be appropriate if there was a close balance between the benefits and the harms, or if we had less certainty in the evidence, or if we had reason to believe that patients' values and preferences, given the same information, would vary appreciably. We took a patient-centered perspective for our guideline. We had 21 members on the guideline panel. These included clinical experts, methodologists, and also 3 patient partners living with chronic pain, including 1 veteran. As a prerequisite to serving on the panel, no member could have any important financial or intellectual conflicts of interest. And we began the process by doing a systematic review of patients' values and preferences. We firmly believe that evidence alone is not enough to make clinical guidance. We need to understand the views of patients. We gained some of that information through the patient partners we work with, but also through a systematic review of the literature on this topic. And we wanted to understand the relative values or importance of outcomes that patients had relative to medical cannabis use. We wanted to understand attitudes and preference for or against cannabis, different modes of administration and formulations for managing chronic pain, and any factors that might influence patients' decision-making regarding whether to or not to use medical cannabis. We found 15 studies eligible for our review. They all reported patient values and preferences of adults. They were largely from the US, but we did have representation from 4 other countries. They were all fairly recent, conducted from 2000 onwards, and both cancer and non-cancer chronic pain patients were represented. We found moderate to high certainty evidence that many patients who use medical cannabis valued the effect it had on their chronic pain, even when experiencing adverse events related to concentration, memory, or fatigue. There was a greater preference amongst those that were using cannabis therapeutically for either balanced ratios of CBD to THC or high CBD products versus high THC. So very distinct difference from recreational users, for example. Their use of cannabis or lack of use was influenced by both positive and negative social consequences. And concerns about medical cannabis included side effects, addiction, tolerance, losing control, or acting strangely. And patients that had more concern about these side effects were less likely to be interested in using cannabis. We found low certainty evidence that there was highly variable attitudes towards medical cannabis amongst people who live with chronic pain, and that some patients were motivated to use medical cannabis as a strategy to reduce their use of prescription medications. And in particular, there was some belief amongst some patients that it might be a safer alternative to opioids. Neither the NICE or the IASP group systematically explored patient values and preferences, so we weren't able to compare our results in that area. We have we have published our work in BMJ Open. It came out recently if anyone is interested. We also undertook a systematic review of randomized controlled trials for cannabis and chronic pain. We found 32, 28 for non-cancer chronic pain, 4 enrolled patients with chronic cancer pain. All adults. Length of follow-up ranged from 28 to 140 days. We did not look at studies that followed patients for less than 28 days. We simply felt that was too short of a follow-up time. Placebo, unfortunately, was the most common type of control. And the types of cannabis, there were some that looked at endocannabinoids, cannabinoids that we ourselves make. Most looked at phytocannabinoids, those that are derived from the plant itself, but 12 studies looked at synthetics. Modes of administration, primarily oral or by spray. 2 studies did transdermal. And interestingly, no eligible trial explored inhaled cannabis, which is interesting when you consider that with the Health Canada data, most patients authorized to use medical cannabis are acquiring dried flower product, which would be inhaled either through smoking or vaporizing in the majority of cases. And the trial evidence does not speak to that mode of administration. So we have here a grade table, and it's a little busy, but I'm just going to focus you on largely the section in red. So this is our outcome on pain relief. And you can see we have a fairly small improvement, 0.5 centimeter on a 10 centimeter scale for medical cannabis versus placebo. And that correlates to a risk difference of 10% for achieving the minimally important difference in pain relief. That means it's statistically significant, but small. You'd have to treat about 10 patients with medical cannabis for 1 to report an important reduction in their pain. When we look at physical functioning, again, we have a significant effect, but it's smaller. Here, the risk difference is only 4%. That means you have to treat 25 patients for 1 to report an important benefit. So that's a very small effect. In terms of emotional functioning, we had high certainty evidence that there is no improvement with use of cannabis versus placebo. And what did some of the other recent guidance say about the effects of cannabis on pain? Well, the NICE guideline basically found very similar results to us. They found a 0.4 improvement on a 10-point scale. Their exact number was 0.44 mean difference. And we had a very similar effect. We had 0.5. We included 27 trials versus the 11 that they pooled, but our estimate was very close. So the question is, why did they conclude this effect was unimportant, whereas we felt it might be important? Well, it seems to be on how this data was presented and interpreted. They stopped at the pooled estimate of the mean. So they focused on that 0.44. They said it's less than the minimally important difference of 1, therefore it's unimportant. But that ignores the distribution around this effect. And we know that some patients achieve more of a response with medical cannabis, some achieve less of a response. And so we felt it was more appropriate to model the risk difference. What is the proportion of patients that are likely to benefit? Because not everyone is going to achieve the exact same response. That was the 10% I showed you earlier. And when we conveyed that number to our patient partners, they largely felt that some patients that lived with chronic pain that had not found relief with other methods might well be interested in a 10% chance of an important improvement. So again, we had the same results largely, but we converted it to a different type of effect estimate. We went back to our patient partners and we received guidance that the 10% chance was not completely unimportant to those who live with chronic pain. What did the IASP say about the effects on pain? Well, they also found benefit, but they concluded that it wasn't trustworthy because the evidence was all contaminated due to risk of bias. They said this is very biased data. So what did we see? Well, we looked at risk of bias as well. And basically we did find that about 1/3 of trials did not appropriately report generating their randomization sequence. They all did concealment of allocation and blinding well, but about half the trials had large amounts of missing data. So why didn't we rate down for this? Well, we looked to see if the differences between those trials at risk of bias were significant in terms of the effects they reported versus trials at low risk of bias. We ran a subgroup analysis for adequate randomization. And we found there were 16 trials at low risk of bias and 11 at high risk of bias. Our test of interaction was not quite significant, showing that these studies were not compellingly different from each other. But here's what's interesting. We assume, or the concern we have with risk of bias is that studies that are flawed in that way are going to exaggerate the effectiveness. We see the opposite here. Studies at low risk of bias actually report a larger reduction in pain than studies at high risk of bias. So if we believe that that bias had been realized, we should be concluding that cannabis is actually more effective. What about the other risk of bias item I mentioned, loss to follow-up? Here we have a meta-regression. So here we have each of these circles as a trial. This is proportion loss to follow-up. This is the effect on pain relief. Negative numbers are better, right? We want more pain relief. We see a same issue coming up here. Studies with more loss to follow-up actually report less pain relief. So again, if we believe this, if we believe these studies are really different, and we only considered studies at low risk of bias, we would conclude that cannabis was more effective on pain relief. But again, we found neither of these subgroup effects to be credible. So we pooled all studies together, assuming the risk of bias had not been realized, and therefore did not rate down our certainty of evidence. Looking at some other outcomes, role physical, social functioning, high certainty evidence that cannabis does not improve these outcomes. Sleep quality, we have a significant but small effect. A risk difference of 6%. Again, you'd have to treat about 17 patients for one to report their sleep had been improved in a meaningful way. And what about reducing opioids? This is something that came up in our systematic review of patient values and preferences. Well, we found, as did the NICE guideline, that there was no effect on providing medical cannabis in terms of reducing opioid dose. Now, the NICE guideline made a strong statement that cannabis did not work to reduce opioids. We, however, rated this evidence very low in certainty. Why did we rate it so low when the NICE document did not? Well, we did it because all 4 randomized trials that reported this outcome instructed their patients not to change their dose of opioids during the trial. So these trials were never designed to inform this outcome. We instead went to the observational literature because we didn't trust the randomized controlled trial data. We found 6 studies of over 700 patients, and they did show that medical cannabis reduced use of opioids amongst those patients by about 20 milligrams morphine equivalent per day. Again, because they're observational studies, they're unblinded, there wasn't a control group. We also rated this very low certainty. But at the end of the day, we don't know at this point whether providing medical cannabis may or may not help reduce opioids. And we've published this in BMJ Open recently as well. What about other adverse events? Well, cognitive impairment. There is a 2% risk difference increase. So again, that's quite small. It means out of every 50 patients treated, 1 will report some transient cognitive impairment. And you see similarly small increases in adverse events for vomiting and drowsiness. Dizziness goes up a bit more. For dizziness, we see about an 8% increase when patients are treated for 3 months or less. And as you get to longer periods of treatment, that risk goes up quite a bit. When we talk about impaired attention, diarrhea, nausea, again, we have statistically significant increases in these risks, but you'll see the risk differences are all fairly small, 3%, 4%, 5%. And again, we've recently published this review in the BMJ, where you can see it for additional information. What about rare but more serious harms? Things like cannabis dependence, road traffic injuries, falls, suicide, or suicidal ideation? Well, we did a systematic review of the observational literature, and unfortunately, there is very little guidance on these outcomes. As you can see, all of our certainty here is very low. We really don't know at this point whether or not medical cannabis increases risk of these harms versus placebo. Now, to whom do our recommendations apply? Well, when we look at the literature that informed our evidence syntheses, again, no trial eligible for our systematic review explored the effect of inhaled forms of medical cannabis or enrolled patients involved in palliative care. And so our recommendation is not going to apply to those groups. It was also worth noting that trials eligible for our reviews largely excluded people who live with chronic pain with concurrent mental illness, those receiving disability benefits or involved in litigation, and they did not report representation of veterans. And so the generalizability of our recommendation to those groups is uncertain. It might apply, but we're not completely confident. So I've just presented you very quickly with the evidence for use of medical cannabis versus placebo on chronic pain. And I think you would probably agree there is not a clear imbalance. We have fairly modest benefits on pain and physical function and sleep, not on other outcomes. There are a number of harms that are increased, but again, largely quite small effects on a number of transient harms. So we have a very close balance, in fact, between benefits and harms. We did have sufficient certainty in many of our estimates, except for those rare and long-term harms. And our patient values and preferences research really told us that patients are likely to have different views based on the evidence. So we're much more in a position where we really have to lead towards a weak recommendation. You'll see a number of these criteria were met. And in fact, that's what we did. So our final recommendation, looking at the evidence, values, and preferences, was a weak recommendation in favor of offering a trial of non-inhaled medical cannabis to those patients living with chronic pain for whom standard care without cannabis had proven insufficient. And again, a weak recommendation means that it's important to sit down with patients and to acquire their values and preferences so that they're able to make a decision that's consistent with their context and their preferences. Now, there are challenges with the practical administration of medical cannabis. We know from work we've done that this is not part of formal training for the vast majority of healthcare providers, and they often feel uncertain about how to administer these products and how to monitor and in what doses. There is consensus documents that have started to appear. This is one that came out about a year ago. There's others that do provide some guidance on how to administer and monitor patients that are interested in a trial of medical cannabis. And so I encourage those that are interested to look at these documents. And that's my presentation, and happy to take some questions later.